All right, hello everyone, and welcome to this Vālenz webinar, Captives of the Future Roundtable. Reduce risks and gain control of your health spend with data-driven collaboration. I am Aaron, your host. We're delighted to have you. Joining us are our featured speakers, Rob Gelb of Vālenz, Phil Giles of MSLS Captive Solutions, and David Vorhees of True Captive Insurance. Now, to introduce our speakers, sharing the mic today is Robert Gelb. Rob is Chief Executive Officer of Vālenz. Vālenz enables self-insured employers to make better decisions that control costs across the life of a claim while empowering their members to lead strong, vigorous, and healthy lives. Vālenz offers transparency through data to pinpoint members at highest risk, address gaps in network designs, ensure appropriate and accurate charges, and expertly navigate employees to optimal care solutions for substantial cost savings and improved health outcomes. So not only does Rob do all of that, but when he's not busy saving people money, he is running 5 miles each morning. Now, joining Rob is Phil Giles, Managing Director of MSLS Captive Solutions. Phil has received multiple awards for his expertise in the captive insurance industry, including Captive Review's Power 50 listing of most influential individuals in the worldwide captive insurance market. Phil's expertise includes self-insurance, property and casualty, captives, self-funding, and employee benefits. Phil is also busy in the mornings. He is out most days riding horses, is a competitive equestrian. And completing the trio is David Vorhees, CEO and founder of True Captive Insurance. During David's 17 plus years of leading human resources and employee benefits, he saw unsustainable health plan rate increases and was determined to create a new solution. David founded True Captive Insurance, providing unique funding for buying power and an improved employee experience. And then David has the wonderful mix of also being a former pilot and a former competitive eater. All right, that material covered. Rob, let's get you and the team on camera, and I'll turn the mic over to you to begin.
Aaron, before we begin, can you pull the first poll up for the group? You know, there's some fun stuff here. If you look at sounds too complicated and unaware of how it would work for us, 63% of the audience felt that was where they sat. And then 13% are already in a group captive now, which means there's room for opportunity. David, Phil, when you look at this seems pretty interesting to me, 63% in those two categories. I think we're going to demystify and maybe unwrap how it could work for people today. What do you think?
Yeah, I'm not.
Oh, go ahead. You know, in terms of being complicated, it's just a matter of some basic education, because it really, from my perspective, isn't much more competitive than a traditional self-funded plan with medical stop loss. It's just a matter of who's holding on to different segments of risk in the program.
Yeah. David, go ahead, bud.
Yeah, I was going to add that it doesn't surprise me in the sense of when I was running HR, I hadn't heard of captives until about 8-9 years ago. And anytime you add complication or something that's complicated to an already difficult or challenging business environment, it sounds like too much trouble. But once you partner with the right groups to figure that out, you realize it's a great financing mechanism to take back some of that control that we felt that we had lost participating in, you know, your traditional insurance benefits.
Yeah, so it's interesting for the audience. You know, part of it, we started to think about what are the goals of really getting through the next, say, 50 minutes or so, and it really was to have an open dialogue with you, of course, through Q&A that you can continue to populate as we go along, and we'll be pulling them off of the screen for those that fit in. Having an ideation or an exploration conversation and recognizing that there's never a situation where one size fits all. And in doing that, we're going to uncover key objectives and goals that all of you might have for your programs or for your clients and customers, employers' goals, and how you can think about building a model that really delivers on plan vision. And when we talk about ecosystem, maybe that's the next piece of this. You'll hear me personally talk about this a lot because we operate as an ecosystem as Vālenz. It's an agile, not fragile design. The idea being you've got to be able to flex and flow with what's happening in your environment. And that's really how we think of maybe designing captives for the future. Maybe the last piece, and then we'll move on, Aaron, and I'll take the wheel. This is a little bit of a how, what, why conversation, and we'll pivot around as we go along in that conversation. So let's begin. The why for today's discussion really does center around this whole idea that costs are increasing, high dollar claims seem to be exploding, and understanding what the key drivers are underneath the hood is critically important as you think of designing a program. This whole concept of risk sharing is something we'll talk about, and I'm actually going to ask David and Phil to comment here in a second about that. And off to the right, you see this traditional approaches don't optimize cost control and health outcomes bubble. David, a wise man named David Vorhees once said to me, there's cost and price, and they are not the same. Can you expand on that a little bit for the audience and kind of get us into that conversation?
Yeah, I think whatever part of this journey you're on, whether you're the buyer, whether you're the seller, or you're the financier, we've been programmed to think about price. So when you're sitting in the seat and you're making the decision on what program you're looking at, somebody brings along a spreadsheet, and that spreadsheet has a lot of different prices on it. And typically, in most cases, you pick the lowest price. But when you're picking the lowest price, you're only picking a cost. You're looking at that simply as a multitude of, or a factor of number or rate. When you think about it in cost, you've got to add more things like what's the employee experience like, what is the continuity and quality of care, all these different components that add to it. So if I'm looking at price, it's a finite piece of time, it's 12 months. If I'm looking at cost, I'm thinking about this over a 3 to 5 or even 10-year strategy, as we know that the claims are increasing, the cost is increasing. So how can we control that and manage that more responsibly, and feeling like you have some sort of catch-all, if you will, of how do you control this yourself versus allowing someone else to do that.
Yeah, I think that's spot on, and I think maybe demystifying, and Phil, I know you like this question that's been shared with us, which is people want a little bit more insight into the value proposition of a captive and how a captive potentially could set them apart from other self-funded options. And the tee up for you would be the misnomer is that the captive itself is the solution, right? That's not necessarily what we're trying to do with that. It's more a funding mechanism. You want to talk a little bit about that for the audience and maybe drive that?
Yeah, and I think the important thing to know is that, as you just said, Rob, that the captive isn't the panacea itself. I mean, the captive is really just a financial mechanism for being able to disperse or diffuse risk over a larger population of individuals. So it's really a financial mechanism for being able to share risk, but it also can help facilitate the increased controls, what David alluded to a moment ago. When you get into the value proposition, we've become a very, the medical stop-loss captive industry has been one of the fastest growing segments in the insurance industry over the last 10 years, and especially over the last 5 years. But with that, that competitiveness, the captive really needs to have a very strong value proposition to be able to distinguish itself in a highly competitive and increasingly competitive market. And it's not really about the captive itself, it's the platform that is behind the captive that's really going to define what that value proposition is. It's going to distinguish it in that market. And that's based on, how well it facilitates cost reductions in medical claims management, that sort of stuff. Again, the whole ecosystem behind it for reducing costs and facilitating control. And increasing member engagement, which is a big segment as well.
You threw a lot in there, and we'll unpack some of that, right? So member engagement seems to be a consensus all-American in terms of the top things that people want to hear about, and how do you do that? How do you, what's the risk of a diverse member population, and what are the types of things you need to consider as you're just talking about quote-unquote catastrophic risk? And maybe the last thing is really around this whole idea of cost containment. And of course, this is not an infomercial. We'll go on record and recording for Vālenz. We're one of multiple solutions in the marketplace for everybody to consider what cost containment could be for a captive offering. The way that we're looking at it for this conversation is how do all the components of cost containment, your navigation, your direction of care tools, your networks, and potentially your non-network contracting and non-contracting approaches, how do they all fit into driving higher quality, lower cost, and less disruption and or abrasion for all the parties that are involved? And so that's really what we think is important in terms of evaluating this, and some of these questions that you have about how do I design them. Those are the considerations we're going to dive into here going forward. So I'm going to pull up this next one, this next page for us. And these are the considerations of what we believe need to be innovated, that whole agile, not fragile design of getting the captive the right way. So there's an underwriting piece and a long-term rate stability piece. I think that we're all wondering what's going to happen in the environment we're operating in today, and what does that look like go forward? How do you close gaps in cost and quality? And then, of course, on the right-hand side, there's some network design, which we want to talk about. Transparent data-enabled decisions. What does that mean? So I'm gonna start there. Data is the fuel that is going to drive everything around success in all of our programs. And using past, present, and potentially future state data sets are really going to be what drives better decision making. Transparency is a big word. We believe that you need to understand cost, David, cost versus price. And really understand what it is you're trying to accomplish with cost management, cost containment in your program, using past clean data, using other tools like transparent data sets. Some of us have heard about Turquoise Health. There's Healthcare Blue Book. There are other options out there. There are UCR data sets. There's paid claim data sets. Using all of that, finding tools that allow you to kind of cut that data and think differently about reimbursement and quality of care. Those are all going to be super important as you design this program. Phil, David, you want to talk a little bit about underwriting, rate stability, and maybe talking about data as well? Because I know, David, we've talked a lot about the importance of data and how you use it and how you interpret it for better decision making. So, David, you maybe want to kick us off?
Yeah, I'll start on the data part because I'm a big fan of data. But remember, my job was serving and supporting the human capital of an organization. So I often get into, I won't say heated discussions, but certainly with underwriting teams when we're talking about our programs, data is something that has happened in the past. It can help us predict the future, but healthcare isn't 100% predictable. Our country, our culture are facing all sorts of different things. And so when we look at data, we use it as a factor to help us understand what might be happening in the future. But things change. So you look at this and you say, here do we think it's going to do? We've got several years that help us make that decision. But then it's really understanding what can we do in real time to help people. I'm going to be most focused on the culture of an organization and the impact that health has on folks. But what I'm most hopeful is that we are able to marry data and marry the people. So then we can make a best-in-class program that uses both things.
Phil, anything to add? Thank you, David.
Yeah, and I certainly agree with everything you said there. And in terms of the underwriting credibility and everything emanating from data, you're both right. Everything does emanate from data, and the more transparent that data, the better. If we know what goes into that data and what creates the data, it's going to help with the underwriting credibility of that data. And really, when we get into the size of a captive and the population within the captive, being able to get increased amounts of data, and the more data we have, more transparent it is, the more credible it's going to be. So when we get into group captives and larger populations with good data, we're going to have more credibility, and more credibility equates to better predictability in the underwriting process. The more predictable it becomes, the better we can put a more accurate and more appropriate price on that risk.
Yeah, and it dovetails into two other things that are on this page. So diving a little bit below the 20,000 foot level, that's where network design really is going to come into play. Understanding the membership, understanding where they're located, understanding the scoring of that health, the health scoring of that population is going to really then help us figure out where are the best providers, what's the best program design. Are you going to go with a fully contracted network? Are you going to go a little bit more aggressive and find a non-contracted program that still focuses on quality, cost of care, and proper utilization. And then, of course, what types of tools are you going to provide both the plan and the member with navigation and an experience that really helps them on their healthcare journey? These are the things that really matter as you start to think about design. Anything else, gentlemen, before I move on?
I want to kind of comment on that too, because networks to us in the stop loss world are everything. You know, we started out very embryonic with basic PPO networks and then gradually gravitated or evolved into RBP programs. Now we get into narrow networks and direct provider contracting, all things that are progressively better in terms of generating savings. And one thing I want to note that there is really no correlation between the cost of care and the quality of care. So what you're paying for care is irrelevant relative to the quality that you're going to get. It's just a matter, right now there's absolutely no controls over what providers can charge, what specialist pharmaceutical companies charge, and it's just a matter of kind of renegotiating that. And a lot of that can be done through network design and being able to kind of reconfigure and negotiate. And we've gotten to things that, you know, when you look at a basic PPO network versus RBP and now direct contracting with providers, that's really RBP on steroids. So we've really come the full range without any kind of sacrifice in the quality of care. So it's just a matter of being able to control the cost in terms of network design, which has, you know, just enormous impact.
Absolutely, and this is where that top of the circle in the center, math matters, kind of comes into play. This whole idea that the highest cost is the highest quality, that's really teaching members through the tools and resources we have available to share with them that that's not necessarily the case, that quality can come at a reasonable cost, and that the right cost is the approach coupled with quality to get the right utilization of service. So we're going to dive into that here. Aaron, why don't you queue up the next poll, because I'm interested to see how folks feel about this topic. This is encouraging, David, don't you think? Phil?
Yeah, absolutely. I'm actually surprised at that result.
Yeah, that is not what we were expecting, but what we were hopeful for. So the reason we asked that was we were talking about data, and what we started to realize is that there is a misperception that we've encountered that the smaller groups, really the group captives, work best for groups of 250 or less. But the reality of it is they work for group size much larger than that and can be very, very effective. David, you talked a little bit about the concept of debt trancing earlier today, a couple of other things that you see as kind of innovation in the space that can help drive some of this risk sharing by all the participants. Do you want to talk a little bit about that in the context of above 250 and why it's so valuable potentially to consider this?
Yeah, I'd be happy to. So it's interesting. Phil had mentioned earlier before about the competitiveness between an individual stop loss plan and a captive plan. And a lot of times, especially from my previous seat, a CEO or a CFO would get very uncomfortable when you talk about risk sharing. And in a captive, it's not so much about risk sharing. It's how you are earmarking or ring fencing certain types of risk. So if you think about the self-funded portion that an employer has, that's theirs. They're underwritten by themselves. Nobody else has any impact on this other than the folks that you partner with to either run your network or do some of your nurse navigation or do some of those other programmatic features. But from an insurance perspective, that risk is your risk. Then in a captive, you pass off that risk to this captive layer, which is where we come in, and we're managing that. So the easiest way to think about that is you've got your layer as an employer, and then we've got our layer as a captive, but that's passed off. So you're not sharing any of the procedures or unfortunate issues that happen. You know, if somebody has a bone marrow transplant, or with COVID, we've seen a record number of double lung transplants. If another company has something like that happen, you're not actually taking on that risk because that's been passed off to us as the captive, and we're managing those claims. So I think a lot of times when we think about how to finance risk, and you're thinking about financing something differently than you were doing before, where before it's, here's a cost, this is the price, you can do as much or as little, but that's the price, it never changes. And then moving into something that has a little bit more variability seems a little concerning, because you're like, I don't want to take on someone else's risk. So I think it's really good to think about how you can look at risk slightly differently, but not take on any additional risk than you might need to. And I think that's a key component, because that's where you create efficiency, because that middle body of risk, we're managing a much larger head count than the company that you sit in. So whether you're in a 50 life company, a 250 life company, even a 1,000 life company, when you join a captive, you're potentially in a much larger group, whether it's 6,000, 50,000, 100,000, 500,000. So you're able to participate in more efficiency because it's blending it across a much larger head count.
I like that, and one of the questions that's popped, I like this question, Dave. I want to share with you and then get Phil's comments on it. Is I'd like to better understand the overall claim process within a captive structure. And just listen, we talk about, is there any difference? Is there really a difference in the claim process? Do you want to talk about that? David or Phil, maybe kick us off on that one.
Well, really, there's nothing different, because in a group captive, the insurance carrier, the issuing carrier, is going to issue a traditional medical stop-loss policy, and everything flows the same way. But you just have to appreciate the dynamics of the captive. The captive is really acting as a reinsurer to the insurance carrier, and so the excess insurance carriers going to adjudicate a claim, facilitate the reimbursement after the employer files the reimbursement, and then if there's anything that penetrates into the captive layer, the carrier is just going to go to the captive and seek reimbursement for its proportional share of that claim. So really, the flow isn't any different at all.
Yeah.
Go
ahead, David.
Rob, I was gonna piggyback off that, and 100%, it is identical. And as Phil mentioned earlier, a captive itself is a financing vehicle, but the managers inside the captive, the people that are participating in some of the member level experiences, when a claim is processed, that's when you can start to really attack the price and cost of insurance. Because think about claims processing is typically an automated process. In a lot of things, you'll hear something called auto adjudication. That means that a claim goes through, a system evaluates what that claim is, its code, it assigns the discount, and off it goes. There's no human catalyst to say, well, wait a minute, was this efficient? Was this correct? Can we call the surgeon and ask if they'd take direct payment? Could we pay early and get a discount? Was it even the accurate amount? And so I think that that's critical to think about. Although the claim itself is identical, whether it's in a traditional or non-traditional way, then once it gets to the managers, the folks that are paid to focus on working on those claims, that's where you create some more efficiency, and that's where who you choose comes into play, because there's a lot of ways to dice this, and some people can be more relentless with their pursuit of creating more efficiency.
Yeah, and again, we're getting some really good questions coming in here. One of them is, I'd like to better understand the captive market, and I'm interested in what qualities make a good long-running captive. And is there, I know you both have, I'm sure you both have opinions on this. Let's start with you, Phil, and then we'll let David kind of take it from there.
Yeah, well, again, the first things that come to me when we're evaluating the captive program is, as we said before, can they present a compelling value proposition? Again, we're in a very competitive market, and with the captive just being a financial mechanism to share risk and disperse risk, hey, that's great, but what's really going on within the captive, the platform, to be able to control and mitigate the risk that's in the captive? So you have to have a good platform for that. Maybe that includes things like reference-based pricing or narrow networks, centers of excellence. Are they working with the right specialty RX manager? That's where a lot of the major savings are going to come from. And Rob, things like predictive analytics and the use of data.
Oh, yeah.
So all those things at the captive layer, but none of this is going to happen without membership selectivity and really good membership standards. So we've never been fans of the programs that just want to open the doors to anyone that wants to come in, and without making a long-term commitment. So some of the more successful programs that we've seen, we're working with one program now that says, hey, we want to foster that collaboration amongst the members. We want to be able to promote information sharing and sharing of best practices among the members, and very collaborative process. They're limiting, to be able to ensure that they can continue to do that, they're limiting each cell in their captive to a maximum of 50 members. They hit 50 members and they're going to split off and make another cell. They just don't want to get too big where you lose that member interaction. But then also have the entry guidelines. Again, the captive can't be a receptacle for people just looking for a quick reduction in premiums. So I think membership standards and trying to find what the the objectives are for that member. So qualifying the broker or the client and their objectives, but also qualify the broker. We don't want there's a lot of brokers out there that are just again looking for a quick reduction in premiums for a client, and that's not what a captive is about. It's got to be a long-term proactive commitment.
Yeah, I think that's right. And David, I'm going to ask you to weigh in too, or yes, and. This question is a great question. I thank the audience member who brought this to us, because the way it's structured, good long-running captive, the captive option really is the long game. And if we really want to be thinking about them. There is no silver bullet. There is no short-term fix. And what's really interesting is when you break down the costs of a program, captive or otherwise, and you look at administrative, just breaking into three parts: medical, which could include pharmacy, administrative costs, and then cost of insurance. Medical and pharmacy is going to be the place where you're going to drive the impact around all of this. And so when we get caught up in these conversations around, well, I don't really want to pay $137 per hour for case management, I want to pay $125, that's really not the conversation that we should be having. The conversation should be having is, what are you going to get me for the case management service, and how are you going to help my member, and how are you going to direct care to the proper facility, whether it's a center of excellence, whether it's a contract, non-contracted quality provider. And so sometimes I feel like we're not having the right conversation around cost and price, David. I know we've talked about this a lot, and the impact that both have on really the effectiveness of a program in or outside of a captive. You want to talk a little bit about that too?
Yeah, I love this question. And it's easy to point fingers at how people run their business a certain way, or they run their business a certain way, because again, a captive is a financing mechanism. I think one of the big components to this, and it alludes to something that Phil was talking about, is what is the reason for joining a captive? Why are you looking at something differently? If you're solely looking for a cheapest price, in many cases, we are the most efficient cost. But if you sell on price, you also lose on price. I know next year a competitor will put out a lower price, which means it defeats the purpose of us working together for a full year to try to get control of some of this. So that's a big factor, is looking at what your intention is of bringing in membership. Now, growth brings financial success. It brings financial stability. And yes, when you grow a program very big, that is helpful, because when you have some of that volatility, that scale can help. So I see that from one perspective, but I really think not necessarily cherry picking or being selective, but make sure that the group, most importantly, does the head of HR, does the CFO, CEO understand that this is the long game. We're not going to go out to market next year and try to find the lowest prices. We're going into a long-term sustainable relationship that for a group of, say, 350, maybe 400, you could be saving upwards of $10 million over 10 years. I mean, when you start thinking about that versus I can save $100,000 this year, and next year I might get an increase of 23%. And the other piece that I would say to this is, it's making sure that the group itself is, and when I say group, I mean the captive, is financially stable. It takes a considerable amount of money to launch and run a captive. And if you aren't responsible as a fiduciary, you can get yourself into trouble by taking risks that you don't need to take. So if you're bringing in a group that's having that bad year and you're trying to do a favor by helping them out, well, you might unnecessarily be putting everyone in this captive at risk. And so I think it takes a program that understands not only what its purpose is to its members, but also understanding that to be there and be them for long term, you've got to have a considerable amount of finances to make that stable. So if you do have the bad year, and it will happen, it will happen. You will have a bad year. That financially the captive can weather that storm and still deliver great value to its members, because at the end of the day, that's what we're here to do. We're here to participate and serve our members.
Yeah, great point, great talking points. And so we've covered some of what's on this page in detail. The last piece, and then Aaron, I am going to ask you to poll the audience with our final poll today. This whole idea of data, we talked a little bit about this in an earlier segment of the conversation, and really the data portion of this is going to affect every aspect of how you look at it from an underwriting perspective, how you look at it in terms of both the individual employers that are joining, as well as that whole central layer, if you will, and then how you're going to manage and control your costs on the medical management side. You're going to use data to really drive and design program that creates flexibility in the way you approach certain types of chronic conditions and risk in your business. And of course, how do you collaborate with captive members to achieve greater profitability? That's going to be varied based on the program that's been put in place. Any comments on that, gentlemen, before I ask Aaron to queue up the poll? Let's take a look at this. So this question was a select all that apply. So we're trying to see where the dominance consists in capitalize and the strength of the captive group. Phil, I see you nodding your head. You like that one. Smart audience, well, right?
Yeah, you know, I like a lot of them here. There's a lot going on with this thing. And obviously the capitalize and leveraging the strength of the captive group is an obvious one, if not the most obvious, because, strength in numbers. And you're able to, again, as we said, diffuse and disperse risk, spread risk, particularly in an environment where you've got increasing instances of large claims activity. This is going to help those smaller to medium-sized employers. So that's an obvious one right there.
What about create an enhanced member experience down around 50%? So of those that polled, just about half checked that box. What do you think of that one?
There's two things that go into mind here. So there's that one, creates an enhanced member experience and helps navigating care, are two of the biggest things in my mind in a successful program. Whether it's a self-insured program, even a traditional benefit plan, we've seen so many benefit plans over the last several years go to high deductible health plans and try and cost shift to employees to be able to reduce the employer costs. Well, that's what we're talking about, finding ways to deliver, reduce the cost of benefit delivery to employees. But, when you do that, you have to realize that the average employee doesn't know how to shop for medical care. It's not like going out and, trying to buy something at Walmart and compare prices. When, the whole premise of a high deductible health plan has been, to facilitate consumerism. Well, consumerism is a great concept in the benefit world, but it has not really been as successful as a lot of people think, just because, who do you rely on? Well, you rely on your primary care physician, because I don't know how to shop for a knee replacement or a hip replacement, or God forbid I get cancer. I'm going to go to whoever my primary care physician is, and can I go shop around for an MRI or a CT scan? I don't know how to do that. So, the problem is they rely on their primary care physician, but there's very few primary independent practitioners anymore. They've all been acquired by larger facilities, and those independent practitioners are now employee practitioners. And so they're incentivized to direct care to specific facilities. They're sometimes penalized if they don't. So what we need when we have a captive program that can help with care navigation, that's going to also accentuate the member experience and enhance the member experience. So those two go in hand in hand. Having a good concierge to be able to help direct care to better care facilities at a lower cost is going to be critical, and that's one of the things that can be promulgated in the value position or value proposition of an effective captive.
Yeah, so we have an audience member. By the way, thank you for this. I love pulling these as we're in flight, right? About this poll, other than 1 and 3, so create similar risk and capitalize in the strength, can you not gain those benefits from merely self-funding and engaging with vendors through your broker? I have an opinion on that. David, I think you probably do as well. Go ahead.
So I do. Shocker, I have an opinion. I'd say this is, regardless of what type of mechanism you're using to finance healthcare, it's critical to people around you and who is executing in that endeavor. And I would tell you that I have had great relationships with some brokers when they were my relationship as a head of HR. I've had others that haven't been as strong. And that's the case in anything, right? There are good captives. There are not as good captives. There are good underwriters, not as good underwriters. So I'm not pointing fingers. I think it's critical in who you select. So yes, you can find those same benefits in individual self-funding, but here's the kicker, and this is what we've been talking about, insulating yourself from risk. So if you're a 200 life group, or heck, let's just say you're a 300 life group, everything's going fine, but you get hit with your adverse year. When you go get underwritten again, now you're being underwritten as a 300 life group. When you're with a captive, you're now under a block of business, and so you're creating efficiency by the scale of your service. So we're block purchasing stop loss as a membership of 25,000 members, and so your increase can be smooth. Your leverage can be smooth because we can go to our underwriting team, or we can go to the reinsurance group and say, hey, the majority of our group ran somewhere between 60 and 70%. I know I've got this 300 life company over here. They had a bad year. They had some unfortunate things happen. They ran at 140%. And I know you want to give them a 15%. But since the rest of our book is around 3 to 6%, let's go ahead and trend that number down because we believe it was a year. It was something that was adverse. And let's go ahead and work on it again. When you're 300 lives, you don't have that leverage. So I think that that's one of the key distribution points of saying you have strength in numbers, you've created efficiency, and you have that ability to make those claims and conversations, and usually people listen.
Yeah, and I am biased as Vālenz, right? So I am biased around the aspect of an integrated cost containment model that has the throughput of claim, membership, and data married together. And so one of the areas, so this also questions vendors through your broker. Absolutely. And I am not talking against that. My point would be inside a self-funded, and in this case, inside a captive, having this continuity where from the time the member enters their journey, they're being directed to care, contracted or non-contracted. Data is being absorbed in some form of a data warehouse where you're constantly taking a look at those claims and assessing and understanding what's happening with them, where risks are lying in the future, and how you can control and maybe have an action, an alert and an action model to take some sort of accountability for improving that before the left turn claim occurs. And so one of the things that I like to talk about personally is this idea of having an integrated offering where all the data is real-time shared, and then that enables you to make some real-time decisions on your program. We find that this model that we've designed inside a captive really promotes that. And Phil, I know when you and I spoke about this, that was one of the things that intrigued you about it was an ecosystem design. I'll take Vālenz out of it. There are others, right? But this whole idea of an ecosystem design of cost containment, where from the time the member calls and says, hey, where can I go and who's the best provider, to the time a payment gets made back to that provider, if it's all managed in sync and all the data is utilized real time, there's efficiency you can have. Yeah, I wasn't sure if you wanted to comment on that whole continuity of cost containment.
No, well, and again, from my perspective, that's what's going to distinguish the program in this market where we're increasingly competitive. And really, it's all about, driving down those costs without sacrificing the care. If we can do that and make those decisions, target the cost drivers, specific cost drivers of a program, and then have the agility to make the adjustments instantaneously, we'll be way ahead of the game.
So I hope the person that asked the question on the poll, we've satisfied your curiosity and your inquiry. If not, throw us another question, challenge us, chastise us, praise us, whatever you want to do. We appreciate all these questions coming in. that poll that we just took in the top three really do align with, okay, so we aligned with what we had anticipated would be the next generation of group captives, which really is this whole idea of safety in the numbers, promoting rate stability by having an aggregate membership, collective predictability inside that underwriting area. David talked a little bit about that, and enhanced efficiency, leveraging the strength of collective membership. So when you think of reducing risk, gaining control of your health plan spend, you know, we took a poll on this as well, and what we found is you could see transparency, which in our environment today seems to be a hot topic. So we'll talk about that in a second. But guys, isn't what you're saying the advantage of points of 1 and 3? And I'm sorry to be, you're not being a pest, whoever's asking the question, we appreciate it. Isn't what you're saying the advantage of points of 1 and 3? So 1 and 3 were again the collective piece, David, and then the other aspects being self-funding versus captive. I'm not quite sure. It's from Peter Travis. Thanks, Pete. We appreciate the question. We want to answer it. This was around, is there a real difference between self-funding and captive?
Yeah. Rob, let me take that for a second, because, you know, I don't want to seem like I know everything, but I have a unique position having been a buyer and being a client to not only an insurance carrier, but also a broker, but now running an insurance company. I think what ends up happening is there are multiple ways to offer insurance to groups, and there are multiple appetites for risk. I think what often happens is you learn to do something one way, and that becomes the most comfortable way to do things. And so it may be a situation where there's a group that does not or is not interested in participating in a captive, or there may be a group that's not interested in looking at anything in the self-funding arena, whether it be individual stop loss or captive. But the critical and most key component is having that discussion with all the stakeholders, and the most important stakeholder, and often the folks that are most forgotten, the group. The person that is consuming the insurance has to look their employees in the eye and say, this is what we purchased for you and your family. Let's ask you, what do you think this should look like? And when they say, I'm not sure, that's what we pay you to do, that's when you get kneecap to kneecap and go, let's talk about this in your verbiage, in your terminology. Let's understand this together. Because, and I promised I wouldn't soapbox, but I am going to for just 1 second and say, the breakage in healthcare, and often the collateral damage, is either the patient or the employee. You've got the rest of us all arguing what the best way to do this is, and we forget that there's a patient or an employee on the other end of this that is screaming for help. How do we take control of this? How can we afford this? How can I have better health care that's available to me and my family? And so I think that the point here and the question that was asked is, you can accomplish this in a multitude of different ways, but the most important thing is understand what the group wants, and then how can you create long-term efficiency in a program? And I think that's the key. We're not looking at a year to year. We're looking at a multiple year strategy. And I promise you, if you sat across from your customer, if you're a broker, and you said, Mr. or Mrs. CFO, would you be interested in saving $5 to $10 million over the next 10 years if we deploy a long-term strategy versus spreadsheeting a plan and sitting in front of them and going, which one would you pick? They don't know what they're doing. They're looking at a spreadsheet going, yeah, this $250,000 plan looks good, having no idea what goes into it. So anyway, long story short, my point is I think it's incumbent of us to really partner with our customers, and those customers are the group, and making sure they understand what they're purchasing and making sure it's efficient for their group.
Yep. And so we have some really good questions are coming in now. So does RBP provide the best network design for the lowest stop loss premium in ag? Phil, 30 seconds.
No, not really. I mean, obviously that's a huge enhancement because network is and discounts are everything to us. But you know, yeah, RBP goes a long way. We, as a stop loss carrier, provide some really significant discounts depending on what the point of reference is. You know, and we want to know that in the underwriting process. But what's even going to get deeper discounts are the direct provider discounting and direct provider contracting, and the narrow networks, which are going to go well beyond that. You know, if you can go in and work out, and we work with several entities that are doing this now, direct provider networks. throughout the universe, throughout their employee universe. So they're looking at where their employee populations are and going in and handling the direct negotiations with specialty providers and formulating the narrow networks.
Yeah, earlier this year, I partnered with Adam Russo from the FIA Group to talk about RBP. And we had a very healthy conversation. By the way, we're happy to share that, a copy of that link too, if people want to hear about that. And it wasn't just unique to captives, but just in general. RBP, you want to definitely understand how the RBP supplier partner is doing the work. How are they selecting reimbursement levels? What are they doing to support the member? How are they limiting abrasion with the provider community so that the next time somebody needs to go see a doc, they can go see the right doc and that doc doesn't push back on you? Contracting is a means of getting that done. So don't want to belabor that one, but great question. Short answer to the question was not necessarily. What are the KPIs that drive a good return on investment for selecting a captive? Maybe better stated, what features should a 200-member employer, parentheses, any size, be looking for in selecting a captive? So, David, you and I talk about math a lot. We love math. Math matters. KPIs are a form of math. They're the output of the work, right, that's going on, and how do you evaluate them? So there's two pieces to that, and then I'm going to ask for your opinion. The KPIs themselves are going to be important, whether that's penetration, whether that's savings, whether that's disruption, whatever the metric is. But then how you use that and understand the trend to continuously have this, again, agile, not fragile mentality of you're going to constantly be looking to enhance and improve workflows and processes and take advantage of the tools you put in front of your members. David, you want to talk a little bit about KPIs, a minute or so? We're running just a little bit long, so go.
Yeah, this is a great question, especially about a 200-member employer. And interestingly enough, and this is where I sometimes differ from my peers in this industry, is that every plan, every group should have a unique component to it, right? I mean, if you look at the fully insured world, we've been regurgitating the same plans and maybe increasing the deductible, but that doesn't count as a differentiation. But if you're looking at a 200-member life group and we're looking at as much claim data as we can get, a lot of times you can't get good actionable results. It has to be anecdotal. That's where that partnership with the group is, you know, talking to the HR professional, the CFO, is someone coming off the plan, is someone in remission, is there something that we can sink our teeth into to give credit? But really, what's most important to your program? You know, do you have a hypertensive group? Do you have a lot of folks that are getting ready to have their first, second, and third child and you need a maternity plan? What are the things that are important to the group, and then insulate and support them with that plan design? I think that's where you get where you get the most bang for your buck and in the weeds with these groups, because every single program should be the same. If you build one program and you have one risk tolerance, you're not going to capture every single thing that you can gain from each program, and you gain efficiency by having 10 programs running 10 different ways, but the best version for each one of those 10 companies. So maybe a one-size-fits-all will help you shave 20 to 30%, but what if each one of them can shave 40 to 50%? You combine 10 times 40 to 50%, I think math does matter, and in that case, you've created more efficiency, the cost has come down, and most important, and again, sorry to beat a dead horse here, but you have a better member experience, better satisfaction. You've got less turnover if you're a broker. You've got less, volatility. We're not having to charge for churn in our insurance, because whether you know it or not, the insurance carriers are charging for the churn. So if people are leaving their programs, somebody's got to make up those dollars. And so if you're not focused on that, then you don't have to charge as much, right? So that's one of those things that I think that you can make a program unique for each person. And it's not that challenging.
Yeah, please don't leave. I see there's 49 of you hanging on with us, and sometimes the best conversation is in the last 3 minutes. What captive type is better, homogeneous or heterogeneous? I have a heavy equipment company, which would seem to be heterogeneous. If I have a CPA firm, it seems to be homogeneous. Any thoughts on this one, homogeneous versus heterogeneous?
Well, I'm a little confused by that last comment about the CPA firm. So
probably multiple CPA firms.
Multiple, yeah. So we have heterogeneity is, non-specific industries. You have a mix of industry classifications. You could have a professional services firm in with a heavy equipment company, all in the same captive. A homogenous is going to be all in the same industry. All hospitals and healthcare entities, all higher ed, all beverage distributors, manufacturing firms. So professional services. There isn't one that's really better than another. What we find is that the homogenous captives, the industry-specific ones, tend to be smaller in terms of the number of members, but larger in the average member size. So if you look at the heterogeneous programs that are mixed industry, you can have a wide spread not only in the types of risks in there, but also the population size. You could have a 50 life employer in with a 500 life employer. Pretty broad range. When we get into the homogenous ones or industry specific, they tend to be already existing self-insureds and with a good track record as a self-insurer, and then want to participate and be able to have that collaborative experience with their peers in that industry and share information. And the average size generally tends to be in the 200 to 750 range there. So not one that's necessarily better than the other, they're just a little different.
So we have 2 minutes, actually a minute now, the clock is ticking. We can extend just a couple of minutes. It looks like we're still holding on to about 45 participants, so we thank you guys for sticking with us. There was one more question in here that I thought might be of interest to the remaining group, which was, is there a difference in what would it be when I think about this between a domestic versus an offshore captive? David, you want to tackle that?
Yeah, I think, again, there's probably not a right or a wrong answer here. Offshore captive cells have been around for a very long time. I think there's probably some efficiency gained to participate in that. For us, it was important for us to be domestically located. If you listen to the State of the Union, specifically called out offshore domiciles and places where there might be tax gains that aren't allocated correctly. I don't think that there's a right or wrong answer here. I think it's the comfort of not only the person running the cell, but its members. I think you still accomplish the same thing because we're regulated in the United States as a carrier. But I think that there's probably a little bit more scrutiny from a taxation perspective locally, and also, in choosing your domicile, if they understand the country in which they're working in, they also can give you great guidance and feedback when there are things that are going on inside of your cell on a yearly basis.
Yeah, Phil, go ahead. 30 seconds.
Yeah, I agree with everything David just said, but now there's 36, maybe 38 domiciles, onshore domiciles that are all very competitive. Believe it or not, the world of onshore domiciles has gotten very competitive. All have very strong enabling legislation. So there really isn't that much of a reason to go offshore anymore, or as compelling as it was a few years ago when you had less offshore options. Offshore, we have a lot of the captive programs making what's known as a 953D election to be taxed as a U.S.-based corporation. So that, if you're doing that, why not just be onshore and, not worry about it, maybe collect some of the tax advantages that may differ from each state. If you don't make the 953D election, you typically have to pay excise taxes, and they're depending on the structure. There's just some additional complexities that I don't think you need to worry about if you're onshore.
Yeah, so for the 40 of you that hung on, we're gonna let you go here in 30 seconds. We want to thank everybody for today's session. We hope that we lived up to both your expectation and our commitment, which was to have an open dialogue, explore as much information as we can about captives and the self-insured market in general, and hopefully promoted some ideas and some tools for you to think about as you go about embarking, solving for the needs of your employers and your partners. Thank you so much to everybody. Have a wonderful, wonderful day.
All right, and indeed, thank you so much, everyone. You all could have been many places this past hour. We appreciate your time and attention. Rob, Phil, and David, thank you for being here to share your expertise. And with that, everyone, this concludes our Vālenz webinar. Have a great day. And with that, we are done.